So you can share the slides now. We have another 2 minutes only. So you can start sharing the slides and Om Prakash sir will introduce you. Dinesh, tu hai kya wahan par?
I press
Share
F5,
screen.
right? Yeah, wait, just a moment.
Yeah.
Share screen, yes. Yeah.
Select the presentation. Yeah. No, it's going to come, but it takes time to upload.
Shall I click share?
Yeah.
Come?
Yes, it has come.
Okay, fine.
Yeah, Vikram sir, I will tell you when we need to go live.
Right. आप बता दीजिएगा. Then Om Prakash sir will introduce Dr. Nikhil. Okay. Om Prakash ji, we have 1 minute to go. Sir, you can click on from the beginning.
1 minute to go.
Okay, wait.
Yeah.
Right?
Right, sir. Perfect. Dinesh, confirm करना अपने level पे. Then, sir, Om Prakash will start speaking. Okay.
Sir, can we start? 6:30. Vikram sir, can I make live, sir?
Om Prakash, you are ready?
Yes, I am ready.
One second, sir. I'm making you live. 1 second. Sir, you are live. You can start.
Om Prakash ji, over to you.
Yeah. Good evening, everyone. On behalf of Lupin Respirators, it gives an immense pleasure to welcome all the doctors for this academic ECME program. I am thankful and grateful to all the doctors who has spared his time for this academic program in this pandemic situation. It's pleasure to have with us Dr. Nikhil sir, an eminent speaker, and for today's ECME program. On behalf of Lupin Respirators team, Nikhil sir, I welcome you for this program and thanking you for accepting this invitation as a speaker, as a faculty for this program. For the just a brief introduction about Nikhil sir to the audience is that Dr. Nikhil sir is a senior chess consultant with independent practice in Mumbai. He is a former assistant professor, Department of TB and Chess Disease, KG Somaya Medical College, Mumbai. He has served as an organizing secretary of 15 national conferences and 9 workshops. Dr. Sarangdar sir was also organizing secretary of NAPCON 2016 Mumbai. Through academician throughout his career, Dr. Sarangdar sir has participated as a faculty member and delivered 48 guest lectures and 99 presentations at various international and national conferences. Dr. Sarangdar sir is the author of 23 chapters in various textbooks of respiratory medicine and published 8 articles in peer review index journals. He has also been awarded as 8 prestigious Young Scientist Awards. Sir, it's a purely pleasure to have you with us as a speaker for this academic program. Please, now over to you, sir. Please take this session ahead.
Thank you all for that nice introduction. And I'd like to thank Lupin and their technical team for arranging this webinar. Firstly, I welcome all of you, our colleagues, who are sparing your invaluable time in this pandemic situation for academic activities. And I hope that you all will benefit greatly from this webinar. So the topic of the webinar is COPD, that is chronic obstructive pulmonary disease, and cardiovascular comorbidities, difficult liaisons. Am I audible?
Yes, sir. You are absolutely perfectly audible, sir. You can continue.
Yeah, thank you. Yeah, Thank you. So before beginning, I'll pay a tribute to the departed soul of my late teacher, late Emeritus Director Professor Dr. K.C. Mohanty, a doyen of tuberculosis and respiratory diseases in the country, who left for his heavenly abode 3 years ago. The topic today is cardiovascular comorbidities in COPD, difficult license. So when we talk of comorbidities or systemic manifestations of chronic obstructive pulmonary disease, you see, today we understand that COPD is a disease that is not just confined to the lungs. This was first believed in the American Thoracic Society, European Respiratory Society joint statement on the definition of COPD, which mentioned that although COPD affects the lungs, it also produces significant systemic consequences. We had the Global Initiative for Obstructive Lung Disease guidelines in 2007 that mentioned that COPD is a preventable and treatable disease with some significant extrapulmonary effects that may contribute to severity in individual patients. The GOLD guidelines of 2011, 4 years later, also mentioned in the definition of COPD, the last sentence, exacerbations and comorbidities contribute to overall severity in individual patients. The GOLD 2020 guidelines this year have defined COPD as a common preventable and treatable disease characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases and influenced by host factors, including abnormal lung development. Significant comorbidities may have an impact on morbidity and mortality. So, dear colleagues, COPD is no longer regarded as a disease confined only to the lungs. Findings of weight loss, muscle wasting, and osteoporosis are attributed to the hormonal imbalance and chronic systemic inflammation associated with severe COPD. Metabolic and endocrine derangements are increasingly being recognized in patients of COPD, as are anxiety, depression, and an increased risk of mortality from cardiovascular comorbidities like hypertension and coronary artery disease. Systemic inflammation and spillover of the inflammatory cytokines and other mediators from the pulmonary parenchyma and airways into the systemic circulation is believed to be responsible for these systemic manifestations or comorbidities associated with COPD. Amongst these include C-reactive protein interleukins, adipokines, other cytokines, and coagulation factors, the levels of which have been found to be elevated in COPD patients, particularly during exacerbations. Why is this interesting? Because anti-inflammatory agents such as corticosteroids that target these systemic mediators may constitute the basis of a novel therapeutic approach in COPD patients. Recent attention to and recognition of the systemic manifestations and comorbidities associated with COPD in the last 2 decades has led to renewed interest in the role of inhaled corticosteroids, as therapy with inhaled corticosteroids has been reported to reduce mortality, particularly from cardiovascular events in COPD, probably by decreasing the spillover of inflammatory mediators and cytokines from the respiratory system to the systemic circulation. So what are the comorbidities that are associated with COPD? We have general comorbidities such as weight loss, muscle wasting, several nutritional deficiencies. We have cardiovascular comorbidities, which is the theme of today's talk. Amongst this includes hypertension, pulmonary as well as systemic hypertension, cardiac failure, cor pulmonale, arrhythmias, atherosclerosis, coronary artery disease, ischemic heart disease, cerebrovascular sleep apnea, which is COPD with obstructive sleep apnea, and the obesity hypoventilation syndrome. Hematologic, such as anemia and polycythemia. Musculoskeletal, which include loss of lean muscle or fat-free body mass, skeletal and respiratory muscle weakness and dysfunction, and osteoporosis. Gastrointestinal, mainly gastroesophageal reflux disease or GERD. Endocrine, such as the metabolic syndrome, diabetes, pituitary, adrenal, and thyroid dysfunction. Psychiatric, any chronic disease will have some psychiatric such as cataract and glaucoma. Reproductive, such as loss of libido and impotence. malignancies, most commonly lung cancer. So you see there's a great interplay between comorbidities and the symptoms of COPD, influenced by age, genetic factors, environmental exposures, with lung pathology and metabolic factors such as inflammation, insulin resistance, and others that are acting in interplay to cause systemic manifestations like, like interstitial lung disease, such as lung fibrosis, lung cancer, pulmonary hypertension, cardiac comorbidities, kidney disease, GRD, anxiety, depression, and a lot of other things. So, friends, the second part of our topic is difficult license, particularly in cardiovascular comorbidities of COPD. So, what is difficult? You see, although most physicians easily recognize the patient with COPD whose management is complex, agreeing on a precise definition of what constitutes a difficult to manage patient of COPD is problematic, unlike difficult asthma. Because we have a definition of difficult asthma, but we don't have a definition of difficult COPD. So, what in a broad sense could constitute difficult COPD patients? What are these patients? You see, any patient I would consider who suffers from severe life-threatening exacerbations, has been hospitalized frequently, requires additional medications or interventions over and above medical treatment, which is optimized, and has multiple comorbidities, a list of which we've discussed already. It could also include patients who can't be controlled on maximum doses of inhaled medications. So, why are these patients important? Friends, patients with comorbidities account for a large share of direct as well as indirect health costs related to COPD care, and they consume a disproportionate amount of physician time and healthcare resources. What could be the causes of difficult patients of COPD? Friends, any airway and just not the inhaler technique, everything else also. Whether the inhaler is appropriate. If there's an elderly patient, 75 plus, having tremors, edentulous, and you're giving him a meter dose inhaler with a spacer, naturally he's not being take it. Poor compliance due to several issues. Drug interactions. You see, particularly in cardiovascular comorbidities, many patients would be on beta blockers, arrhythmia, heart failure, hypertension, etc., and they hinder the action of beta agonists naturally. Patients of TB who are on rifampicin, patients on carbamazepine, these enhance the clearance of inhaled corticosteroids. Indoor and outdoor pollution, smoking, infections, coexisting lung disease like asthma, COPD overlap, bronchiectasis, and lung cancer. Other comorbidities which we discussed, such as cardiovascular ones, diabetes, obesity, sleep disorders. Coming to cardiovascular comorbidities, I've discussed before that long-standing complex interactions exist between the pulmonary and cardiovascular systems in COPD, and they tend to be more common, particularly in smokers. Of interest, hypertension, pulmonary as well as systemic, that is thought to result from smoking-induced vascular inflammation and remodeling, resulting in pulmonary right ventricular dysfunction and cardiac failure. Increased fibrinogen levels, neutrophil activation, endothelial damage, and platelet aggregation by microthrombi predisposed to atherosclerosis, which is further aggravated by dyslipidemia due to increased low-density lipoproteins. Particularly in smokers, smokers have higher serum levels of carbon monoxide, which shift the oxygen dissociation curve to the left, thereby impairing oxygen delivery still further. Carbon monoxide also stimulates the development of polycythemia due to an increase in red cell mass in hematopoiesis. This, along with increased fibrinogen levels, contributes to a rise in blood viscosity and predisposes to thrombosis of myocardial stroke. And this gives rise to transient tachycardia. So, regarding COPD and cardiovascular disease, cigarette smoking is a common risk factor to both systemic inflammation and endothelial dysfunction. Vascular are key pathogenic factors, particularly for atherosclerosis, as you can see here, and several processes are thought to interact with each other, particularly lung hyperinflation, hypoxemia, and hypercapnia. pulmonary hypertension, and systemic hypertension. Also, systemic inflammation and oxidative stress due to the spillover of inflammatory cytokines and compounded by exacerbations. Acute coronary and cerebral syndromes in COPD are thought to arise from the interplay between these mechanisms. Amongst the arrhythmias, atrial fibrillations are the commonest arrhythmias encountered. Right ventricular arrhythmias are seen more commonly in patients who develop cor pulmonale. Cardiac failure is seen in as many as 10 to 46% patients of COPD. And what's surprising is that even in a study, 40% of patients who are hospitalized for cardiac failure showed some evidence of COPD. So it's a bidirectional interaction. Airway obstruction also correlates with cardiovascular comorbidities in COPD. There is now ample evidence supported by epidemiological studies to show that both morbidity and mortality in COPD patients with coexisting cardiovascular disease, particularly coronary arteries and atherosclerosis, correlate with FEV1. The risk of death due to fatal cardiovascular events in COPD increases by 28%, and the risk of hospitalization for cardiovascular events by 42% for every 10% decline in FEV1. The overall risk of death due to a cardiovascular cause in COPD is as high as 75% for patients with lower FEV1. Comorbidities affect outcome in COPD patients. As you can see, a cardiovascular comorbidities are associated with mortality, quality of life, poorer health status, more dyspnea, less exercise capacity, frequent hospitalizations, and more healthcare utilization and expenditure. So, what will you do when handling such patients? There are some questions that you have to ask yourself as a physician. Is this purely COPD? Establish a diagnosis of COPD and establish a diagnosis of persistent airflow limitation by a spirometry with bronchodilator reversibility. Apart from COPD, is there any underlying lung disease? You can get this by imaging of the lungs, X-ray, CT scan of the chest, bronchoscopy for any airway disease or lung cancer, sputum and serum eosinophils and other markers, inflammatory markers for asthma, COPD overlap and other disorders. Are upper airway disease and GRD contributing? History, sinus imaging and endoscopy for upper airway disease and 24-hour ambulatory assess whether these are comorbidities that are contributing in such a patient. Smoking, environmental and occupational factors. Remember in the definition we had noxious particles or gases and infections. All these could contribute to a difficult COPD case. So how will you manage? Friends, with the close association between COPD and cardiovascular disease, it is possible that treatments for one condition would definitely influence the other. Therefore, appropriate treatment of all associated conditions is essential. You must investigate for and treat comorbidities, cardiovascular comorbidities, ECG, echocardiogram, gastroesophageal reflux, dietary history, 24-hour pH and esophageal impedance monitoring, sleep apnea, history, snoring, polysomnography, obesity, simply take the body mass index, and psychological disorders. Of course, any chronic disease of which COPD is one, you have to address, counsel, and treat accordingly. Encourage smoking cessation if the patient is a smoker at any point in time during the course of management. Vaccination, again, to prevent or reduce the frequency of exacerbations. All patients of COPD should receive polyvalent pneumococcal vaccine once every 5 years and seasonal influenza vaccine at least once a year. Pulmonary rehabilitation, certainly. Each patient must have a written action plan that would promote rational stepwise use of drugs depending on disease severity and patient affordability, discourage polypharmacy, particularly which is common in elderly patients, and will include also a list of what to do. This is drug therapy as per the GOLD guidelines. We have a lot of drugs there. I'm not going into the details, but I've kept this slide for reference. You know that according to GOLD guidelines, we have combined clinical and assessment of COPD. So patients are categorized into group A, B, C, and D. in such patients. Bronchodilators remain the mainstay of COPD treatment as COPD is primarily an airway disease. Bronchodilators can definitely be combined with inhaled corticosteroids for greater efficacy, fewer adverse effects, and reduction of exacerbations. Despite the clinical benefit of inhaled long-acting beta agonists in patients with COPD, these patients would be at an increased risk of cardiovascular complications. The evaluation of safety data from several clinical studies with salmeterol, which is a long-acting beta agonist, demonstrates no clinically significant effect on heart rate or blood pressure in patients with COPD, and we shall see this subsequently in the next slides. There's a lot of research on the cardiovascular safety of long-acting beta agonists or LABA. Both inhaled beta agonists and anticholinergics are two main classes of bronchodilators. Increase the heart rate. This increase in heart rate may lead to ischemic events, probably because beta agonism has a stronger effect on the cardiovascular system than anticholinergics. Beta agonists, however, are considered important cardioprotective agents. Antagonists, like beta antagonists, are used for many cardiovascular diseases such as hypertension, arrhythmias, cardiac failure, and they are considered important cardioprotective agents because of their anti-ischemic effects. Whereas beta agonists not only increase heart rate, increase myocardial oxygen demand, but they also have the potential to cause direct myocardial injury or necrosis that can lead to ischemia. In addition to this, beta receptors are present on numerous inflammatory cells, which could contribute to the potential for inducing systemic inflammation and thereafter spillover and therefore several adverse effects. Some LABAs have been implicated in prolonging QTC interval, decreasing potassium levels and glucose concentrations, which could lead to arrhythmias. We had a systematic review and meta-analysis on the cardiovascular safety of salmeterol. This included 12 studies with 1,661 patients of asthma, not in COPD, but asthma. But they found there was more efficacy with salmeterol, particularly in some outcomes such as percentage decrease in FEV1 after inhalation of methacholine and the number of days without an attack. And the administration of salmeterol seemed to be beneficial for patients as compared to formoterol. Here again is another study on the cardiovascular safety of salmeterol. 1,410 patients of salmeterol were compared with 1,243 patients on placebo. The mean 24-hour heart rates and the QTC intervals at baseline and endpoint were more or less similar in the salmeterol and placebo groups, and a pooled analysis indicated that salmeterol conferred a similar cardiovascular safety profile as compared with placebo. So what will we use in these patients with COPD with coexisting cardiovascular comorbidities? LABA, long-acting beta agonist, combined with ICS, that is inhaled corticosteroids. ICS are potent anti-inflammatory drugs. It's been found in studies that they did not increase the risk of acute myocardial infarction. On the contrary, low-dose inhaled corticosteroid reduced myocardial infarction risk in patients with COPD. So which LABA ICS will you prefer? There are several. We have salmeterol, formoterol, and we have the ultra long-acting current. We have new LABAs like we have now corticosteroids, several beclomethasone, budesonide, fluticasone. Which one? In my patients of COPD with cardiovascular comorbidities, I prefer salmeterol and fluticasone. And I'll tell you why. Salmeterol has a greater affinity for beta-2 receptors. It has non-competitive and slower dissociation as compared to formoterol. That means it also acts as a partial antagonist at beta receptors, and that may account for its relative cardiovascular safety. Fluticasone is a potent inhaled corticosteroid which has higher lipophilicity and a longer duration of action. Why the combination of salmeterol and fluticasone? You get bronchodilation without cardiac acceleration. And it's relatively safe in cardiovascular conditions. We all are aware of the TORCH study. In the post-hoc analysis of the TORCH study, the occurrence of cardiovascular adverse events and serious adverse events which were assessed, and they found that the probability of cardiovascular adverse events at 3 years was least for salmeterol fluticasone combination at 20.8%. And you can see here, this is the lower line is salmeterol fluticasone, and the probability of cardiovascular serious adverse effects at 3 years was least for salmeterol fluticasone at 12.5%. The probability that an extreme cardiovascular adverse outcome at 3 years was lowest for salmeterol fluticasone at 11.3%. Sorry, salmeterol fluticasone combination did not increase the risk of cardiovascular events, particularly in patients with moderate to severe COPD. Therefore, it concluded that salmeterol and fluticasone are not harmful to cardiovascular health. The combination, you see, of systematic review of 27 studies of salmeterol and fluticasone found that a likelihood of having a cardiovascular adverse event at 3 years was similar with a combination of salmeterol and fluticasone in comparison to the monocomponents, that is either salmeterol or fluticasone or a placebo. There was a 17% lower risk of all cardiovascular adverse events with the combination of salmeterol and fluticasone as compared with placebo. Long-term use of salmeterol and fluticasone did not increase the risk and rate of cardiac death. In a subset of patients with prior history of myocardial infarction, the cardiovascular risk was not increased with salmeterol and fluticasone as compared with placebo. So inhaled corticosteroids and their combinations with long-acting beta agonists are not associated with increased cardiovascular risk, though some ICS may seem to increase the risk of pneumonia. The cardiovascular safety of salmeterol in COPD has been demonstrated. The LABA-ICS combination of salmeterol and fluticasone is cardioprotective. Therefore, salmeterol-fluticasone can be safely used to alleviate symptoms, improve lung function, decrease exacerbations, and improve the quality of life. So, we shall go to a case now, which will demonstrate. All right. So, the 60-year-old male patient, an ex-smoker, known case of COPD on therapy, complained of worsening breathlessness and anasarca since 3 days. During the previous year, he had seen 2 exacerbations, which were mainly infective. Otherwise, his breathlessness was satisfactorily controlled on regular therapy with inhaled LABA-LAMA. Examination revealed a conscious, cooperative, and well-oriented patient who was afebrile, tachycardic, normal blood pressure, tachypneic with a respiratory rate of 24 cycles per minute, hypoxemic with arterial oxygen saturation on pulse oximetry showing 82% at room air, elevated jugular venous pressure, facial puffiness, anasarca, pitting edema over both lower limbs, and chest examination revealing bibasilar crackle and S3 gallop. So, what is your differential diagnosis here? It could be, of course, the patient is an exacerbation of COPD, in respiratory failure. You have to rule out pulmonary thromboembolism and right heart failure, and both of them could coexist also. So the first thing you will do is a chest X-ray, correct? Chest X-ray here showed hyperinflated lung fields, as you can see, prominent central pulmonary artery markings, peripheral oligemia, vascular capitalization. These indicate sometimes pulmonary thromboembolism, though they are not very specific. Low flat diaphragms, which are classical of COPD, and bilateral CT angle blunting as well. Hemogram showed polycythemia. ECG showed P pulmonale with right axis deviation. Arterial blood gases revealed hypoxia and hypercapnia with respiratory acidosis. Echocardiography showed a dilated right atrium and right ventricle. You can see here dilated right ventricle and right atrium as compared with left ventricle, and you can see the size is more than the left ventricle. Flattening of the interventricular septum as compared below. Normal size left atrium and left ventricle, normal ejection fraction, moderate tricuspid regurgitation, and pulmonary hypertension with right ventricular systolic pressure of 55 millimeters of mercury. Doppler ultrasound of both lower limbs, which we do to check for a deep venous thrombosis, was normal. So we made a provisional diagnosis of acute exacerbation of COPD with pulmonary hypertension and right heart failure. Initiated treatment with non-invasive ventilation, that is bilevel positive airway pressure. Oxygen at a flow rate of 2 liters per minute. Nebulization with levosalbutamol and ipratropium, which are short-acting beta agonists and short-acting antimuscarinic agents. Diuretics, empiric broad spectrum antibiotics to prevent bacterial infection. Clinical improvement followed thereafter, and then the patient was further evaluated by a computerized tomogram of the chest, which showed features suggestive of emphysema, an enlarged medial pulmonary artery with diameter of 3.6 centimeters. So that is suggestive of pulmonary hypertension as well. After improvement, this patient was discharged with advice for rest. Therapy was changed to inhaled LABA ICS, that is salmeterol and fluticasone, low salt diet, domiciliary long-term oxygen therapy, that is long-term LTOT, because of the P. pulmonale and polycythemia, polyvalent pneumococcal and seasonal influenza vaccination at follow-up, and pulmonary rehabilitation. Subsequent follow-up course over 2 years shows that the patient is compliant with inhaled LABA and ICS, that is salmeterol and fluticasone, compliant with oxygen therapy, clinically stable, no increase in symptoms, and has been exacerbation free for over 2 years, which is a good message. I told you we had 2 exacerbations each year. So friends, what are the take-home messages? Cardiovascular comorbidities in COPD impose a considerable burden of management of the disease. The treating physician may adopt any of the modalities available to assess cardiovascular comorbidities in COPD and revise treatment accordingly depending on availability and resources. Bronchodilators remain the mainstay of COPD. Patients has been demonstrated. The combination of LABA with ICS has also been demonstrated to be cardioprotective. In patients of COPD with cardiovascular disease, salmeterol fluticasone can be safely used to control symptoms, decrease exacerbations, and improve quality of life. Dear colleagues, I am grateful to all of you for giving me a very patient hearing. Thank you.
Thank you, sir. Now I request all the doctors or delegates who can ask the questions, whatever you have any query related to this program.
Yes, I think we are getting some questions. So I'll just take some. Right. So just a moment. Yeah. Can I start? Hello.
Yes, sir, you can start.
Yeah. Okay. No, there was no audio in between, so I thought it was okay. So there's one question. Do you recommend stepping up to ICS LABA therapy in newly exacerbating COPD patients in this COVID scenario? It's a very good question, very pertinent one. So the point here is that there is a concern about safety of inhaled corticosteroids during viral pandemics. We know that corticosteroids particularly reduce not only inflammation, but they also reduce the immune response. And there is some fear that this could be detrimental. Actually, you see what is recommended by the Global Initiative for Full of Asthma, that's GINA, as well as Global Initiative for Obstructive Lung Disease, is that if the patient is already on inhaled corticosteroids and well maintained, you can continue inhaled corticosteroids. There is no need to decrease or step down with the dose. If they are well maintained, there is no harm. Yes, for greater control, because exacerbations are reduced with inhaled corticosteroids, you may also increase the dose. Now, stepping up to ICS LABA therapy in newly exacerbating COPD patients, yes, for a certain period, definitely, because ICS has been known to decrease the exacerbation. So once the patient has been treated from the exacerbation, I would recommend that you do give an inhaled LABA ICS combination, yes, or a LABA LAMA ICS. Also, nowadays, triple therapy is available. Wait for a few months and then think, if the patient is well controlled, what to do further with therapy. There is also some benefit. Some studies have shown in few patients that inhaled corticosteroids actually reduce the pulmonary inflammation associated with coronavirus infection. Some of the studies have been done with beclomethasone, cyclesonide also, not with fluticasone, of course. But this is, of course, data in a few patients, and we'll have to wait till evidence is there. Second question, does nicotine replacement therapy really help long-time smokers? Well, yes, it is important, particularly for patients of COPD. I said, smoking cessation is an integral component of management. We know that smoking cessation rates are very poor across the world. So whatever help you can get from nicotine replacement therapy is important. It is imperative to understand patients may feel, the question here is with long-time smokers, those who've been smoking for 30, 40, 50 years. Lung damage has already occurred, so why stop smoking? The point is that even if you continue smoking, it will accelerate the rate of decline of FEV1. And like I told you, a lower FEV1 will contribute more to cardiovascular comorbidities. So if through nicotine replacement therapy, you can quit smoking, at least that rate of decline of FEV1 would be far less. So yes, it is beneficial, certainly. Now, what are the third question? What are the special considerations for comorbid COPD patients with respect to pulmonary rehabilitation? Certainly, see, any patient you see who is in classification of 1, 2, or 3 of MRC scale of dyspnea, definitely you can refer such patients for pulmonary rehabilitation. The advantage of pulmonary rehabilitation are that not only in cardiovascular comorbidities such as cardiac failure and others, you see you have muscle deconditioning even otherwise, reduced exercise tolerance, and pulmonary rehabilitation helps in all this, apart from better relief of symptoms as well. And then you see, not only with respect to deconditioning, I told you there is muscle wasting. Pulmonary rehabilitation also helps here. And it has better quality, it can give patients a better quality of life. You see, even in 70-year, 80-year-old patients with a MRC of 4, we have tried pulmonary quite successfully. Again, there is anxiety and depression associated with COPD, and if the patient, as there is with any other chronic disease, because of the disease itself, no matter how well controlled it is, and pulmonary rehabilitation has a positive impact on this as well. Another question here is, if you had to choose between faster onset of action and longer duration of action of a COPD drug, what would you choose? Well, you see, ultimately, it depends on what you require for the patient. Ultimately, all LABAs will give you a longer duration of action of COPD. Okay, regarding formoterol and salmeterol, ultimately formoterol is somewhat more faster acting, but then the efficacy of salmeterol and safety, particularly in patients of cardiovascular disease, is found to be better. Do you think before initiating these pulmonary rehabilitation programs, this is the next question, by the way, it's important to get a baseline ECG done? Yes, of course, you would do it in any elderly patient of COPD. You would look for coexisting cardiac disease. You would definitely get an ECG done. The importance of getting ECG done is that it also rules out arrhythmia. If the patient is having an arrhythmia, you would not refer the patient for pulmonary rehab upfront, you see. Next question, could you please explain the importance of regular patient counseling in the pandemic scenario where the comorbid patient may have a tendency to become depressed? Very valid, very pertinent question. You see, now there are several factors that can cause anxiety and depression, like I discussed earlier. One, the patient is elderly. Secondly, he is having COPD. He may be having some other comorbidity, some other illness, which is again itself, you see, any chronic illness, I said, can cause depression. Again, one more is that during this coronavirus pandemic, you see, most of these patients, though they are elderly, they are retired, they are staying alone, they are not getting things. Some of them are pensioners, they are not getting their pension in time. But then coronavirus itself is a great cause of anxiety and worry for everyone. These patients have children and grandchildren. Grandchildren are not being able to go to school. Children, even if they are staying far apart, are not able to earn. So it is a stress for the whole family ultimately. Certainly, regular patient counseling is important in this scenario, and this will stay for years to come because we don't know how long corona will last. Maybe 1 year, perhaps. Hopefully, when we get a vaccine, certainly things would improve. But certainly, patient counseling and is very important in these situations. So acute coronary event increases COPD exacerbations. How to manage this patient? So I think naturally I said cardiovascular comorbidities are associated with COPD. Acute coronary means coronary thrombosis or myocardial infarction or other things. So certainly you would have to manage these based on a physician or a cardiologist. Whatever they prescribe, whatever they manage is up to them. As a chest physician, you would not be managing these patients. You would be managing the COPD component, certainly, but not the cardiac component. What Next question. What is the take on non-smokers COPD and use of salmeterol fluticasone use? Okay, so you see, non-smokers COPD and smokers with COPD. Basically, COPD is there in both. The non-smokers, because they are not smoking, they have a lesser chance of systemic inflammation and spillover. But even in them, the comorbidities do exist. The systemic manifestations do exist. So ultimately, irrespective of what combination you use, you see whether it is salmeterol fluticasone, formoterol budesonide, formoterol fluticasone, ulaba like indacaterol and other things. Ultimately, each patient will behave differently, whether a smoker or non-smoker, whether an ex-smoker or a non-smoker, whether an ex-smoker or a smoker. So you have to match your therapy to the patient's symptom control and whatever the patient tolerates best. Next question is use of indacaterol in COPD with cardiovascular comorbidity. What is your recommendation? Well, indacaterol is an ultra long-acting beta agonist, you see, which can be given once a day. Again, there is some data to show that indacaterol is also effective and to some extent safe. We don't know how safe, but yes, it's safe in some patients with of COPD with cardiovascular disease. One of the reasons it has to be given once a day. It also acts with selective affinity and has a partial agonist effect at beta receptors. So it can also act as a partial beta agonist. So these drugs are just like salmeterol per se. So these drugs are considered to be somewhat safe. But there is more data on salmeterol and much less on indacaterol per se. How to manage COPD plus pulmonary embolism? Yes, you would manage. I told you in our case also, we were suspecting pulmonary embolism as one of the effects. So you would give the treatment for pulmonary embolism first. You see, you would give inhaled bronchodilators for COPD. You would nebulize this patient. You would treat the respiratory failure. You would manage the pulmonary embolism as well. You would manage the pulmonary embolism as well. Nebulization with plain LABA, do you recommend? Well, you can nebulize with LABA or SABA, you can nebulize with ICS. You see, there is no question of what you can use during nebulization and what you cannot use. Whatever is available, whatever the patient tolerates, yes. However, nowadays, why this question is important is because many elderly patients of COPD, they cannot take inhalers, particularly a meter dose inhaler with spacer or dry powder inhalers. So most of them are dependent on nebulization for drug relief. So yes, you see frequently we see many elderly patients coming to us and asking that they cannot take inhalers, can we start nebulization? And yes, it is an accepted form of therapy now. LABA nebulization for patients of COPD. Many drugs are there. We have long-acting antimuscarinics as well, such as glycopyrronium, which is coming up in the market also. And certainly, yes, you can reuse depending on what the patient can take. Certainly, there's no harm in giving nebulization with plain LABA if the symptoms are controlled and if the patient tolerates it. for exacerbations, you recommend macrolides and theophylline. Well, macrolides, yes, macrolides have got an anti-inflammatory effect. Keep in mind that when you're dealing with cardiac patients, drugs like azithromycin can also increase the QTc interval. So you have to be careful of the safety there. Okay, but yes, macrolides have been found to decrease the frequency of exacerbations. Now, in patients of COPD who are having frequent exacerbations, you see that is more than two or more exacerbations per year, or even one exacerbation which is serious that leads to hospitalization. Yes, you can give a course of macrolide therapy. It does help. Theophylline, again, these are cardiac patients. We know the adverse effects of theophylline very well. So theophylline also has some anti-inflammatory effect, yes, but I would not recommend giving theophylline to a patient of COPD with coexisting cardiac disease. Macrolides, yes, theophylline, a strict no-no.
Sir, now I think this was the last question
Right.
till now. Okay. Now there's no more questions. If I sincerely thank you, sir, for taking this session and wonderfully explaining this topic of COPD and comorbidities. And very sincere thanks to all the delegates who are attending this program. From my entire team of Lupin Respirators, I thank you for doctors for taking out your time in this busy schedule of pandemic and giving sparing time for this event. And we promise you from the Lupin Respirators, we will be keep on doing such high-end academic program where you will find all the information. And if further if you have any queries related to today's program, you can feel free to ask to our team members of any of our team members of Lupin Respirators. Thank you, doctor. Thank you, all delegates, and special thanks to all the doctors fraternity for this pandemic situation, for showing your love, courage, and dedication, and standing in the forefront in this COVID situation and treating the patients. Please do take care of yourselves, all doctors, along with your patients, sir. Thank you very much for giving your time.
Can I add a few words?
Yeah, please, sir. Please,
Yeah.
please.
So thank you, Om, and thank you, Team Lupin, for inviting me. First and foremost, I'd like to thank all our guests. I won't say participants or delegates, I will say they are our guests for sparing the invaluable time in a situation like this. For learning about COPD, we wanted to do this webinar because every time we have webinars mainly on COVID and coronavirus, so we wanted to do something different. I'm very happy that it was successful and that we have got a good number of pertinent questions from the attending doctors. Last but not least, I would like to tell all of you, dear colleagues, please take good care of yourself and your near and dear ones and stay safe always. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.